Thank you very much indeed, Christopher Court, for inviting me here. It's a pleasure to be talking to you about the basic setup of the machine and really getting things ready for obstetric Doppler examinations. We've got a fantastic program today and tomorrow, but it's pretty important before you start Doppler. Many of you will be pretty advanced in Doppler. Some of you will be starting. Some of you will be using Doppler occasionally, but it is, we think at ISWOG very important to have some standardization of how to do it. So I hope by the end of this lecture I'll have convinced you of the need for possibly a little bit more standardization and a little bit more teaching of how to do the Doppler. So what am I going to be talking about today? Well, I'm going to be talking about the three modes of Doppler ultrasound, the three commonly used modes. So if I can get this laser pointer working, there we are. Power Doppler, energy Doppler, which is non-velocity based Doppler that tells you about particularly low flow vascular beds. We'll talk a little bit about that, but this, although it's fitted to all machines and was greeted with a lot of excitement when it first came out on machines in the late 1990s, really it's still a relatively niche application of Doppler. Color flow imaging is, of course, one of the mainstays of Doppler. You put on color flow before you put on a pulse wave Doppler gate. And color flow is particularly useful, so not just for looking at waveforms, but for delineating the anatomy of tumours, or if you're looking for a kidney, that sort of thing. Spectral pulse wave Doppler is what I'm going to be spending much of my time discussing this morning, because this is really the nuts and bolts of Doppler. This is the key part of Doppler that allows you to get quantitative information, measure things, velocities, resistances. So it is quite important that we're clear that we are all measuring in a similar way, or at least know if we're not measuring in a similar way. Doppler used to be quite simple. Many of you will not remember the early continuous wave machines that looked a bit like a Dalek on Doctor Who with a little transducer that was shaped like a pen. And those machines had about one or two buttons. You obtained a Doppler waveform that was often pretty hazy, and things have gone a long way in 20 years. So we've now got machines that are incredibly complex, and you've got machines that when you switch to a Doppler setting, suddenly all these buttons become available for Doppler settings. So this is a Siemens S2000. You move into Doppler, and all these buttons lit up are to help you optimize the color flow image and also the Doppler waveform. The fascinating thing is, if you watch people routinely do Doppler, as I often do, even very senior and experienced doctors, and I'm not saying they must change all the buttons, but very few of them actually bother to adjust very many of these settings. That's what I'll be going through bit by bit this morning. So does it actually matter? Well, it does if you want to obtain correct anatomical information in color or E or power Doppler modes. It does if you want to look at a waveform. Specifically here, you'd think of a uterine artery waveform where you'd be looking at notches, end diastolic flow, possibly. But of course, the main application of getting Doppler right and using pulse wave Doppler is to measure the waveform quantitatively. Now, whether that is an RI, or PI, or if you're from the US and SD ratio, or velocity, which could be a peak velocity, time average velocity, TAMX, you then need to standardize the waveforms, because if you don't, the information you get will vary from machine to machine, and it'll vary from patient to patient and unit to unit. So a raised PI in one unit using one machine in a certain way may not be the same as that somewhere else. I'm also going to talk at the end, the bit that everyone groans about but is becoming increasingly important, safe Doppler practice. Becoming increasingly important, of course, because of the context of using Doppler, and particularly ductus venosus Doppler, for first trimester screening. So let's get going. This isn't the wrong slide in the wrong lecture, although you may think, what on earth is this man talking to us about nuchal translucency and fetal medicine foundation accreditation? Well, the FMF realized at a very early stage that if you were going to measure a nuchal and base a risk assessment on it, and I apologize for this nuchal, this is a very early picture from the start of the FMF accreditation process, you needed to standardize your measurements. So there are very specific didactic instructions to everyone, and most of you in the audience will know this because many of you will be nuchal accredited, I would guess, as to the size of the baby, the gestation, what view you take, what the image size is, what setting you use, remove tissue harmonics there, neutral position away from the amnion, where you put your calipers. Where do you put your calipers? All these things also apply to Doppler, although we don't usually think about it. We don't think about Doppler in the context of changing settings and standardizing. So anyway, before I embark on the various settings, we'll talk about a few basic things. One of the basic things with Doppler is it creates energy, of course, and it creates a lot more energy than basic B-mode ultrasound. So if you're going to use Doppler, particularly in the first trimester or in the brain at any point, don't just put the color flow on. You can see many of the vessels just in B-mode. We can see here in B-mode ultrasound, can you see the circle of Willis there? And you can see the middle cerebral artery. So often a way, if you want to get good at assessing vessels and vascular anatomy, is to look at it on B-mode imaging first before you actually put a Doppler gate on. In fact, you could put a Doppler gate on without even using color and be pretty sure that you've got the middle cerebral artery there on the wing of the sphenoid bone. Why is that important? Well, it means that you are reducing the exposure of a fetus to Doppler, particular time when you may be training and exposing that baby to 10, 15, 20 minutes of Doppler. So you can see a lot in B-mode imaging. And the same is true for uterine artery, although of course it's much less important from a safety point of view. Looking at the mother's circulation, we could see the external iliac, internal iliac artery, and if I play that again, you can just see, I think, the uterine artery crossing there. So my point is that you can see a lot without actually using Doppler before you move on to Doppler. Yeah, here we are on one of the other machines. See the uterine artery beautifully before we put the color Doppler on there. So you know that's the external iliac artery, and you know where the uterine artery is as well. The other thing is that very often you get a large expanse of baby or mother, and in fact the bit you're looking at, the bit between the Doppler gate, is about that big. So if you're going to look at vessels, measure peak velocities particularly, possibly even look at vessel diameters, please magnify up the image. So here we have, just using a standard res or zoom box on any machine, you've magnified up and suddenly you've got a huge vessel here, and you can very easily see the angle between the incident beam and the vessel, measure that angle if you want to, but importantly you know that the gate position is in exactly the right place and the vessel you're measuring is exactly the right one. And if we're going to measure, as we often will be, you will often have breathing movements if you're measuring the umbilical artery, middle cerebral artery, ductus venosus, and vessels close to the heart. We, as a convention, will of course measure consecutive symmetrical waveforms, and as a convention, in most of the papers on Doppler, or many of them at least, you will see that authors have said we measured three consecutive similar waveforms. With auto measure, as we have on this machine, it's changed a bit because you can, of course, measure as long as you have symmetrical appearance of the waveform. So you don't have to measure 3, but you have to measure consecutive similar waveforms. So it's important also to not to assume when you move from B mode to Doppler that you just forget what you learn in B mode. And if you're going to do effective Doppler in the first trimester or third trimester, you may very well have to change transducers from transvaginal to higher frequency probes to lower frequency in late gestation. So that's just as important in Doppler as it is in B mode imaging. So, for instance, if we look at this image, this is a 7 megahertz probe. We've got relatively poor penetration on a kidney here, poor color sensitivity. Exactly the same kidney in at 4 megahertz. So changing the probe or changing the probe frequency improves your color sensitivity very significantly there. You'll be very relieved. I'm not going to talk about the physics of Doppler in great detail, except to say that, of course, if the incident beam is at right angles to the vessel, you will apparently have no flow. And it may seem obvious, but it happens every now and again that someone will come to me or come to one of my colleagues and say, look, it looks as if there's no flow here. And, of course, they're looking at right angles to the beam. Ideally, we should be closely aligned to the beam for Doppler images. So this is position A, showing you a nice waveform there that is not squashed or flattened. Position B, what's happening here is that the incident beam is much more perpendicular, much more close to 90 degrees, and you're getting a flattened waveform. Here, a little bit away, the waveform jumps to the other side of the baseline. D, better angle, but negative. So that is basic physics, really, and we just need to be aware of that, particularly in velocity measurements, because, of course, what happens is if you have an angle of greater than 60 degrees, certainly like this and like that, you'll get a relatively poor quality waveform, and no matter what you do to that waveform, in changing the scale, reducing the gain, you will never get a very good quality waveform. Ideally, there's a consensus that ideally we should be measuring at less than 30 degrees. And you can see that in this image. This is a perfectly nice waveform, but it's not an acceptable waveform. And it's not acceptable because if we look at this angle here, it's probably about 50 or 60 degrees. I haven't actually measured it, but it's about 50 or 60 degrees. And that means that of course, you can change the scale here, but the quality of the waveform will never be brilliant. So try and bring that angle down as much as you can. Every machine displays various components of the Doppler waveform and the settings in a slightly different way. So this is a classic sort of image of B mode with color flow and then a frozen image with the pulse wave Doppler. And there are multiple measurements there. And I'm going to go through a few of them. I'm going to talk particularly about the scale. I'm going to talk about angle correction. I'm going to talk about sweep speed. And I'm going to talk about some of these settings as well. But I'm going to take them one by one rather than go through this slide and the next slide in a didactic way. But I do want to just show you that color flow controls work for color flow, and the same controls also work for pulse waves. So I'm sure you're aware that power will determine, the power button on your machine will determine the TI of the Doppler image, on the Doppler image. Gain frequency, PRF, pulse repetition frequency, also called the scale. Area of investigation. If you've got a very large investigation box in color flow, you have a very slow frame rate or a slower frame rate. If you zero down to get a much smaller image size, you will get a much higher frame rate and better resolution. So it's important when using color flow to use the smallest box that you can. So first, look at it in B mode, see where the vessels are, and then try and zoom up that vessel and give yourself as small an area of investigation as you need. Focus, just as important in Doppler as it is in B-mode imaging. And then, of course, you move on to your waveform. So you move on to spectral, what is called either spectral pulse wave. Doppler, I'm going to call it pulse wave, which is its commoner name. Again, power, and this is where you'll see the high TIs, thermal indices, if you're not careful. And I'll talk about that at the end. Gain, pulse repetition frequency is very important in helping you get a good waveform here. And gate size is moderately important. And the effect of a filter can be significant in pulse wave imaging. So let's take these one by one. What about the gain? Well, sounds obvious, but you will, if you flood the image with gain, then you will obviously not be able to see the vessels because there'll be a lot of extraneous artifact. Turn the gain down a bit, and you need to calibrate this virtually every time you do color flow imaging. You want to turn the gain down so that you can see the vessels you want to see, but you don't get this extraneous artifact. And of course, turn the gain down too far, and you'll see absolutely nothing. And that's another common cause of concern, that a sonographer or sonologist unfamiliar with a machine thinks the Doppler is not functioning, thinks it's not working, rings the engineer, and the gain is completely down. Our good old uterine artery again. So this is optimal, and now look at that gain. I've flooded the image with gain, and if you do that, you just can't see what you need to see, and the vessels all merge into one. It's very similar to reducing the scale so that every bit of motion is picked up as color, and you can't distinguish one from the other. And too high gain causes noise, causes crosstalk, and you can sometimes get bits of waveforms that wouldn't have been apparent had the gain turned down. So there's artifact in virtually every Doppler image. The key is to try and reduce it and focus on what you're trying to look at. And you can get ghosting of the femoral arteries. Can you see from multiple reflections if you turn up the gain? So getting reflections, you're getting artifact, and you just don't want that in your image. And gain is, of course, important also in pulse wave Doppler. So this is a uterine artery, and we're turning the gain right up. Okay, you can see the vessel well, and we reduce the gain, and you can reduce it virtually to black. You can completely lose your waveform there. So the key is, again, in every single waveform, just adjust the gain slightly. You see, you've got this sort of image, which is reasonably crisp. And you probably need to do that every time you do pulse wave Doppler assessment. Now, baseline. Again, many of you may feel this is quite obvious, but most machines default to a neutral position for the baseline. So when you move on to pulse wave Doppler, the baseline is completely central, which will not be ideal for positive flow, and it won't be ideal for negative flow, so you need to adjust that. You can see here on a loca reducing the baseline and suddenly seeing the uterine artery Doppler. Let's just do that again. So the baseline you can see started in the middle. You've got to bring it down or move it up if you're wanting to see reverse flow. The invert function, it's a button that is always there and a lot of people don't press, but someone who's particularly malevolent in your department might have pressed it. And it, of course, inverts the Doppler scale. It doesn't invert the image, it inverts the Doppler scale. I'm just showing you this. It's very clear here that blood flow away from away from the probe is blue and towards it is red, simply because the scale is that the high velocities are red and the low velocities in blue. You can equally well invert that and make it the other way round, so it doesn't have to be. So if it appears that the blood is flowing in the wrong direction, just check the invert button, which will invert the color scale. So let's move on to the scale. I've talked quite a lot about scale already. It is probably the most important, I'd say, the most important setting for certainly pulse wave velocities. If you look at the umbilical artery and the umbilical vein, so you've got the cord here, you've got artery and vein, so you've got high and low flow in the same image. You're never actually going to get a velocity that is perfect for both. So you need to decide what it is you're looking at. Are you looking at the umbilical vein, or are you particularly interested in the umbilical artery? Here we have a velocity scale of 64. Now at 64, you're seeing very good arterial waveforms, and it appears that there's no flow in this bigger vessel next to the artery. But of course there is flow, and when we reduce the scale, you can see both the artery and the vein. The problem here is that you can see the vein nicely because these velocities are much more matched to vein velocities, but you've got aliasing, so you've got a multicolor effect there for the artery. So it's always a compromise, and certainly if you're looking at vascular beds where there's a combination of high and low velocity flow, no one setting is going to be perfect for either of that. So it's up to you to decide, and then you'll get the image you want. And this, of course, is the case if we look at, I think this is the femoral artery. If we have a high scale here in the artery, you'll see the artery well. You won't see what's underneath it, which is the vein. So it's just simply not detecting venous velocities. It's not that they're not there, it's just that you can't see them. And exactly as in the previous image, a low scale pulse repetition frequency, you can see the artery, but there's aliasing, and you can see the vein, which now suddenly becomes apparent. If we take probably the commonest application of this, which is the umbilical artery and vein, so in severe growth restriction you may be looking at both the umbilical artery and vein. I'm going to ask you to just look at these numbers here, which denote the velocity scale, as we insonate the umbilical artery and vein. So we're at a relatively low scale here, and we're going up, 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 31, 35, 39, and suddenly we're losing the vein, and everything's becoming either red or blue because you've blunted the velocity range. All you are seeing is the arteries going to and fro, and we've come right down in velocity again, and everything becomes a mishmash of color. So let's just do that again and just look at the scale here as the image changes. So scale going up, 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 you're losing the velocity range, but you are seeing directional flow towards and away from the probe. The velocity is now coming back down, and you're getting artifact, but you're also seeing artery and vein all in one image. And of course, if you've got too low a velocity scale, you will never get a good image for anything. So you won't actually see the umbilical artery properly to be able to measure it. You just see a combination of umbilical artery and vein. And it's equally true for other vessels. So let's go to the uterines. Uterine artery, watch the scale here, 24, 28, 31, up to the late 30s, and you're suddenly losing the vein, aren't you? 49, so it appears there is no vein there. You're just seeing the artery, and the velocities there are right for the artery, not right for the vein. That's at 54. So we went at the start from 24, where you saw the vein and the artery, to 54, where the vein disappeared completely, and all we saw was the artery. Here we have an umbilical artery waveform. We've got a scale there of 11, and if we just look at this artery, problem there is that we haven't got a great waveform. We haven't maximized the scale to allow us to see the waveform. We've got a waveform that is about half or even a third of the size it should be. Very simple to deal with. We should just change the scale. And of course the velocity scale here is actually too low. So we can see all the diastolic flow, but we've lost all the systolic peaks. So the thing to do here is to raise the scale further, and then suddenly the waveform will come down and flatten. And I'd say this is probably a reasonably good image of uterine artery Doppler, where we're filling much of the screen with the waveform. So you can tell a measurement here, you'd be able to, if you manually measured, you'll be able to trace pretty well around that. An auto measure on any machine also depends on the quality of the waveform. Auto measure would work very well on that, whereas it might not work so well in, well, it'll work in that image, it certainly won't work in that image. So here I'm just changing the scale. You can see the scale moving and the systolic peaks changing as I make the scale smaller. Let's just do that again. So look at the scale on the right here. So high scale moving to a lower scale as those peaks increase. So the scale is really critical in allowing you to get a really nice pulse wave Doppler waveform. And again, it's one of these things that you just do need to change for every single time you measure pulse wave velocity waveform. I'm not going to talk about aliasing too much, but this is really about matching the scale or pulse repetition frequency to the speed of blood flow in the vessel. If you've got very, very high velocity flow, you need a higher PRF or higher scale. If you don't get that, you confuse the machine, and the machine thinks that blood is flowing in reverse when it's in fact flowing forwards, because the pulses sent out are being sent out too slowly, and they're not catching the waveform in time as it moves through its cycle. So aliasing, the thing to do here is to almost invariably increase the velocity scale and move the baseline if you need to, or else you will get this very odd sort of image which you can't measure at all. So why does the scale matter? Well, if it's too high, you get a squashed waveform and greater measurement variability. If it's too low, you'll get aliasing, particularly high velocity flow. This is particularly an issue in cardiac Doppler, but also in fetal Dopplers. And you'll cut off the systolic peaks if the scale is too low as well, and you just won't be able to get information from the waveform. Let's talk about angle. Intimately related to scale and velocity is angle, particularly, of course, if you're measuring velocities in the heart, and there is a controversy about whether we should be angle correcting in the middle cerebral artery if you're looking at peak systolic velocity for fetal anemia. Generally speaking, it's easy in the middle cerebral artery because the vessel is almost directly aligned to your beam most of the time, because the baby's head is in the transverse position. But if you're measuring velocity for other reasons, you probably need to angle correct, probably. Angle correction isn't something that happens in real time while you're scanning. It's normally performed on a frozen image, and all it does is mathematically corrects for the velocity of the blood flow by calculating the cosine of the angle. And you tell it what the angle is. So for instance here, if you look at what I'm doing, I'm changing the angle. There's a little line there that I'm changing, and that angle is changing the velocity up here. So the greater the apparent angle, the higher it corrects your velocity. And if you can see there, we've got a velocity there of 1 meter per second. If we play that again, we start at about 96, 80, 73, 67, 73, 78, 81, 87. And that is between an angle of 20-something and 49 degrees. So the angle does make a very significant difference to velocity. Angle doesn't make a difference to PI or RI, but it does make a difference to velocity. So just be aware of that. And certainly if you're measuring off 20 or 30 degrees, further on than 30 degrees, say 40 or 50 degrees, purists would say you shouldn't be measuring a velocity at that angle, but if you do, then angle correction will at least prevent some of the larger measurement errors. Sweep speed. Okay. Again, one of those buttons that people fear to press, don't often press, but you can optimize by matching sweep speed to heart rate. So generally speaking, you want a slower sweep speed for maternal and faster for fetal. So you want to be able to, this is all about just showing a good quality image. And this is reasonably good. That's possibly a little too fast a sweep speed. And you want at least 3 or 4 waveforms to see them properly. So here, a little bit slow and getting faster. So that's important both for fetal and maternal. If you've got your sweep speed, and these are often preset in the machine, so unless you actually do something about it, it will just sweep at that speed throughout. And if you're measuring this umbilical artery PI, you'll be asleep, and so will the mother by the time you get to this other end. So just adjust that sweep speed and save yourself a bit of bother, because why do you need 30 or 40 waveforms? You actually only need 3 or 4 waveforms. You don't need to spend ages looking for that waveform. But of course it can be too fast and shoot off, and it can be even faster than that. If you, in extreme circumstances, you can end up with only 1 or 2 waveforms on your entire pulse wave graph. And here you can see, again, exactly the same umbilical artery. We've got here an optimal waveform, very good for measurement. If you're going to auto-measure, this will work. And if you're going to manually measure, you can very clearly see the shape of the waveform. I promised Christoph I wouldn't overrun by more than 5 minutes. Let's move a little bit to gait. Now, high velocities are in the center of the vessel. So if you use a very, very small gate and it's in the center of the vessel, you will overestimate the high velocity component to a waveform. If you increase the gate size, you will then see all the velocities in the waveform. And you can see here, with the very small gate size in the middle of the vessel, you've lost a lot of the lower velocities. With the gate size slightly larger and at the periphery of the vessel, we've suddenly brought those into play. So just be aware that the gate size should probably match the size of the vessel, approximate to the size of the vessel, and it should be positioned centrally, or else you will oversample parts of that flow velocity waveform. So that won't affect PI and RI, or shouldn't, but will affect velocities. Filter. In most obstetric settings, we just remove the filter completely. And the thing here is that if you have a filter on, you will remove part of the waveform, particularly if you're looking at umbilical artery end-diastolic flow, or you have quite a squashed waveform, a poor angle. If you then add a filter to it, you can lose half your waveform and make it uninterpretable. So generally speaking, we say take the filter off for your assessments. Slightly different in cardiac, but certainly for most obstetric settings. Right, we're coming to the end, and I just want to talk for the last 2 minutes on safety. The issue is really thermal effects in diagnostic ultrasound. It's not cavitation or other mechanical, although, of course, these effects can cause physical effects on tissue. It's thermal effects in the context of Doppler and B-mode imaging. And it's heating of tissue as ultrasound energy is absorbed. So the really important thing here is to know where the TI is. So thermal index is, you can see it on every machine. And here we have TIB, bone, cranial, soft tissue. So display here, this is very high TIs, 4. It should really be at 1.5 or 1. And that image is very little better. In fact, you could argue it's worse than this image here. Can you see? And the TIs here, 1.3, 1.1. Now, this is about adjusting the power on your machine. I don't know how many of you routinely adjust the power setting, the acoustic power on your machines, but it's something certainly if you're doing first trimester Doppler examinations, find out where the power button is and adjust it, because that will determine the amount of energy going into your Doppler image. And a TI of 4 is really far too high to be routinely scanning, and certainly in the first trimester. Very significant heating effect. A TI is the ratio of power used to that required to raise the temperature in tissue by 1 degree centigrade. Does this matter at all? Well, I'm going to just show you 2 recent papers. Rat ductus venosus and apoptotic liver damage. Have any of you seen this paper? It's just out online first. The great thing about the White Journal is you have accepted manuscripts that you can download as PDFs before they come out in the journal. This was a beautiful study, and it involved using ultrasound on rats. Ultrasound of the ductus venosus in rats. Now, whoever did these scans must have been brilliant, because I find it difficult enough sometimes 12 weeks in a human fetus, but for a rat fetus, the ductus venosus, very difficult. So some of these rats, of course, many rats have 5, 6, 7 fetal fetuses. So some of these were exposed to ultrasound and others weren't. Mean 5 fetuses per mother, and ultrasound of the ductus was used for 3 seconds to up to 10 minutes. And what did they find? They showed very significantly that the longer the ultrasound time while measuring the ductus, the higher the apoptotic rate, so the higher that cells were dying in the liver. And that was related exponentially, actually, to ultrasound time, very clearly. And they said reversible damage was noted after pulse Doppler imaging in an in vivo fetal liver tissue model. 10 seconds was the maximum exposure time to ensure absence of damage, and I think it was 20 seconds. After 20 seconds, you invariably got damage. So that's an important study. It's a fantastic study, and the first time that I've seen that sort of work carried out on Doppler in a meaningful way that can translate to the sort of thing that we do in humans, first trimester ductus venosus Doppler. Now, chick brains, I bet you didn't know that there is a whole science about chicken memory studies. So ultrasound exposure of the fetal chick brain effects on learning and memory. So you've guessed it, these chicks were exposed to ultrasound and exposed to Doppler. At 5 minutes and 10 minutes, there was no difference between controls and sham exposed and B mode ultrasound exposed chick memory. But they also did Doppler, pulse wave Doppler. 5 minutes of pulse Doppler on short, intermediate, and long-term memory retention. So there was no real difference in time after testing, but there was a very, very significant decrement, reduction in chick memory after exposure of the chick brain to Doppler. So again, a fantastic study from, that was from Melbourne, from Monash, in 2009, in quite an obscure journal that I don't normally read, but it's just food for thought. We should just be thinking about that. And we should especially be thinking about that because the TI in those examinations was less than 0.1, a tenth of that we suggest in human studies. Now, I'm not suggesting that chicks and rat livers are translatable to humans, but what I am saying is that we just need to think about this. So I will leave you with a few of the basic key points that we've talked about. I don't think you'll need to write them down because they are pretty straightforward and simple, and they're on all the buttons on the machines that you use every day anyway. But I'm just simply going to ask you possibly to look at them again, and those of you that don't, try using them and optimize your images using them. Thank you very much. That's my talk.